Good evening, everyone. Thank you for joining us today. My name is Katie Corais, and I will be your moderator for today's session, hosted by Blink Anesthesia. We're thrilled to have you with us for this important discussion on how quantitative neuromuscular monitoring is reshaping anesthesia practice and improving patient safety. We'll have time for Q&A at the end, so please feel free to submit your questions in the chat at any point during the presentation. Our presenter today is Blake Ward, CRNA. Blake recently completed his 25th year of service at the University of Mississippi Medical Center. He's a graduate of the UMMC School of Nursing and the University of Tennessee Memphis Health Science Center School of Nurse Anesthesia and served as UMMC's Chief of Anesthesia Quality and Education from 2019 to 2025. Since 2016, Blake has used the TwitchView Train of 4 monitor to advocate for patient safety. Through his advocacy, he has been selected as a healthcare hero and top 50 under 40 by the Mississippi Business Journal, served as president of the Mississippi Board of Nursing, published 22 articles, and has delivered anesthesia in 37 hospitals across Mississippi, Tennessee, Wisconsin, Michigan, and Central Africa. With that, please join me in welcoming Blake Ward as he leads today's discussion.
Thank you so much, Katie, and thanks to everyone who is logged in tonight. I think that this will be a very interesting presentation, and I do believe that it is certainly going to spur additional thought and questions and introduce a new way of thinking about paralysis and reversal in ways that we've never thought before. We have always wanted to return patients to 100% muscle function after the administration of paralytics, but we've never had the technology to show us when patients are actually recovered or not. We'll go into some of these details. We'll cover a lot of information today, and we'll have question and answer time at the end. So welcome for Quantitative Neuromuscular Monitoring, a new era. I hope you enjoy. The objectives: we will review the new ASA practice guidelines for monitoring and antagonism of neuromuscular blockade. We will review the history of peripheral nerve stimulation and proper technique. We will also introduce everyone to quantitative neuromuscular monitoring, and I have no disclosures. We'll start with the history of neuromuscular blockade and monitoring. In 1947, the discovery of neuromuscular blocking agents revolutionized the practice of anesthesia with the synthesis of galamine. That's when we started injecting paralytics into patients. 1958, 11 years later, the use of a peripheral nerve stimulator was suggested for the diagnosis of prolonged apnea after the use of said neuromuscular blockers. 7 years later, Churchill-Davidson wrote that the only satisfactory method of determining the degree of neuromuscular block is to stimulate a motor nerve with an electric current and observe the subsequent contraction of the muscles innervated by that nerve, which brought along what we know as twitches. 5 years after that, Ali defined what we were looking at, and he introduced the train of 4 count. Of course, that ranges from 1 twitch to 4 twitches. 11 years went by, and after observing that train of 4 twitches were absent, so train of 4 is 0 during deep neuromuscular blockade, but patients were still moving and breathing. Advancements in neuromuscular monitoring continued with the discovery of the post-tetanic count, which typically ranges from 1 to 15. This is what has changed the entire practice in January of 2023 when the ASA issued their new guidelines for neuromuscular block, monitoring, and reversal. This is an excerpt from Clinical Anesthesiology describing those changes. It was in January 23 when the ASA published their first ever practice guideline called 2023 American Society of Anesthesiologists Practice Guidelines for Monitoring and Antagonism of Neuromuscular Blockade, a report by the American Society of Anesthesiologists. In that report, they issued 8 recommendations that changed the entire practice of paralysis and reversal for the future. These guidelines can be found on the ASA website in this page under that highlighted link. We'll quickly go over the ASA recommendations that they outlined. Number 1, when neuromuscular blocking drugs are administered, we recommend against clinical assessment alone, which is what we've always done, right? They recommend against that in order to avoid residual neuromuscular blockade due to the insensitivity of our assessments, the insensitivity of our eyes to detect paralysis. Number 2, we recommend quantitative monitoring over qualitative assessment. So use a monitor, do not use your eyes if you want to avoid residual neuromuscular block. Number 3, when you are using the quantitative monitor, we recommend confirming a train of 4 ratio greater than or equal to 90% or 0.9 before you extubate the patients. This should be documented on your anesthesia record. Number 4, we recommend using the adductor pollicis muscle for neuromuscular monitoring, not the eyes, of course. Number 5 is where it states that. We recommend against using the eyes for neuromuscular monitoring. Number 6, we recommend sugammadex over neostigmine at the deeper levels of block, which include deep, moderate, and shallow depths. Of course, if you have given ROC or VEC, if you want to avoid residual neuromuscular blockade. Number 7, we suggest neostigmine as a reasonable alternative to sugammadex at only minimal depth of block, when your patient is at minimal depth, which is defined as 4 twitches and 40% train of 4 ratio or greater. And number 8, in order to avoid residual neuromuscular blockade when using atracurium or cisatracurium, of course, neostigmine is your only alternative there. We recommend that you use a quantitative monitor. However, if you are using qualitative assessment, antagonize with neostigmine only at minimal neuromuscular blockade, of course, and then wait at least 10 minutes. And then, of course, confirm that the patient has achieved 90% before extubation. Okay, so fast forward from January of 23 to April of 23, given that the ASA had published these new recommendations, I decided to look into UMMC's practice. So I took a small snapshot of the UMC Department of Anesthesia sugammadex usage. I looked at 7-day periods, Sunday through Sunday, and over that random 7-day period, a total of 53 patients had received sugammadex. Interestingly, exactly 0% of those patients received the FDA recommended 2, 4, or 16 milligrams per kilo of sugammadex. Not a single person had administered the FDA recommended dose of the drug. 16 of the 53, 30%, actually received less than the lowest recommended dose of 2 milligrams per kilo. This brought several questions, of course. What guideline are we actually using in the administration of sugammadex? The ASA guideline continues to warn that fixed dose and blind sugammadex administration, like 200 milligrams or 400 milligrams, a vial or 2 vials, still may not result in full recovery if you are not on a monitor. Now, 87% of our patients were administered a fixed dose. So the ASA is warning expressly against the exact practice that we are doing. UMMC was able to avoid the ASA's warning of blind dosing since we do use monitors for our patients. Noticing that there were so many inconsistencies on what we were doing and our current practice, I began writing. I continued to write until I felt like all of the issues at hand had been fully explained, and these are several of my articles that I wrote specifically regarding the practice of neuromuscular block and reversal. Then I continued to write, and the AANA journal took up and published an article that I submitted to them titled The Rise of Quantitative Neuromuscular Monitoring. It is located on their website in this edition in June of 2023. So let's first discuss what is a twitch anyway. As we already went over, Ali invented twitches, and we have been looking at monitoring twitches our entire life. So we will just look at this video. I have a quick snapshot video where I stimulate the patient's ulnar nerve and monitoring the adductor pollicis with the Blink TwitchView monitor. And we will all look at this and see if we can determine how many twitches this patient has. This should be a very easy exercise. There are no tricks here. Here we go. Play this one more time. Okay. It is very clear that the patient's finger twitched 4 times. I think we can all agree on that. So I believe that everyone would agree that we would call this 4 twitches. So we will then go to the Apex Anesthesia Board Review text. This is what senior students are studying to pass their board exam. It is very clear, and we've all learned this same exact information, that when your tidal volume is normal, you can still be 80% paralyzed. What is the most common thing that I hear in the operating room? Oh, they've got good volumes, pull the tube. Well, tidal volume is actually the least sensitive of the assessments to determine whether the patient has residual paralysis. It makes no difference whatsoever what their volumes are. It is not an indicator of full recovery. Train of 4 with no fade. You get a new battery, you put it on their temple or their ulnar nerve, you zap them really hard with the tetany, no fade. They can actually still be 70% paralyzed, and you think that they're fine to extubate. Vital capacity greater than 20 mils per kg. You pass that at 70% paralysis. Sustained tetany with no fade, 60% paralysis. You pass that test. Double burst with no fade, 60% paralysis. Inspiratory force, better than negative 40. You pass that test at 40% paralysis. Or sorry, 50% paralysis. Head lift, 5 seconds. We do that all the time, 50% paralysis. Hand grip, same as pre-induction. 50% paralyzed passes that test. Holding tongue blades in your mouth, 50%. We can go on and on. Subjective tests, these subjective tests that we always have used are all no indication of residual paralysis. This is the up-to-date continuing education course underlined here. Evaluations of train of 4 made subjectively with a peripheral nerve stimulator cannot assure adequate recovery. It just can't. Why we rely on the peripheral nerve stimulator is something that we are still trying to figure out why we ever began having faith in it. Facial nerve stimulation is less accurate than ulnar nerve stimulation, but may be necessary if surgical positioning limits access to the hands or feet. It is less accurate. That's why the ASA says to use the ulnar nerve. When you use the peripheral nerve stimulator in the ways that we traditionally have, 52% of your patients will go to the PACU paralyzed. This has been studied in hundreds of articles, and they all agree. Somewhere between 50 and 60% of your patients are in the PACU still paralyzed. So let's figure out why that is happening. We don't believe that it is, but it actually is. So let's determine what the proper peripheral nerve stimulator technique is. This is straight out of the textbook that we all read and studied, and we pass these tests in order to become anesthesia providers. The first thing that you would ever do is to determine which nerve and corresponding muscle group you want to stimulate, because we all understand that onset and recovery from neuromuscular blockers occurs at different rates in different muscles. Are we going to monitor the zygomatic, which would be the orbicularis oculi? Or are you going to look at the temporal, which would be the corrugator supercilii? I would suggest that no one does this. Facial nerve electrodes also, where are you placing them? They are to be placed on the mastoid process and just anterior to the tragus of the ear in order to minimize the risk of direct muscle stimulation. Remember, we're doing direct nerve stimulation. This is a peripheral nerve stimulator, not a peripheral muscle stimulator. So we're just trying to get the nerves involved here. So we're supposed to place it in front of the tragus of the ear or on the mastoid process. Most that I've seen goes on the temple. Then, once you have it placed properly, you will induce the patient. Then, three, you immediately, before you give a paralytic agent, you get a baseline train of four. Who does this? I would suggest that no one does this. When we get the baseline train of four, we're to find the lowest electrical impulse at which the patient twitches 4 out of 4 times. So you'll start at maybe level 2 on your peripheral, and let's say you get 2 twitches. Then you go to number 3 on the dial, and you get 3 twitches. Then you go to number 4 on the dial, you get 4 twitches. That is when you stop. You will then stop, and that is your baseline. The patient has 4 twitches at level 4 on the dial. Any milliamperage that you crank up above this minimum is known as a supramaximal current. It will then stimulate the muscle groups around the nerve, and we are supposed to be avoiding direct stimulation of the muscles. Then, number 4, now you have your baseline. You then administer the paralytic and monitor the loss and then the return of those 4 twitches at that level on your dial. So then when someone comes in to relieve you for lunch or break, you will report off that the patient's baseline is 4 twitches at level 4 or level 5 or whatever your baseline level was. Then, as I mentioned earlier, if you overstimulate, your contractions will occur. You will achieve muscle contractions even during deep neuromuscular blockade. And that is the reason that we are thinking that the patients have more twitches than they do because we're overstimulating them. So when you do the peripheral nerve stimulation technique properly, the way that I described, step by step, you can then, what this does for you is you have now properly executed it. You can now perform a train of 4 analysis in which fully reversed and 75% paralyzed patients look identical to you. You will overestimate the twitch recovery by at least 2 twitches, which then causes you to administer the wrong reversal agent in the wrong amount, and then still 52% of your patients will go to PACU still paralyzed. As we can see, there is a lot of room for improvement here in this area, and that's what Blink and TwitchView does for us. Again, back to up to date. When assessing the train of 4 count, clinicians tend to overestimate the train of 4 count when using the subjective evaluations, especially when patients are at moderate levels of block. 10 on the temple is not a technique. It is not located in any medical literature, in any textbook, anywhere in the history of anesthesia. However, that is what we do. That is exactly what we do. We put 10 on the temple and we shock the patient's eyes. It is not located anywhere. We made it up. When you do this, 96% of the time, we will think that the patient has more twitches than they actually do. The other part that plays into this is that from anesthesia in 2019, there are exactly 2 methods to determine twitches. There are 2 methods for us to determine how many twitches this patient actually has. The first method of 2 is the evoked motor response can be measured manually by palpating the twitch. That's one method. The second method is by using a monitor that measures the twitch quantitatively. So which one of those 2 methods did you use earlier to determine that that patient had 4 twitches? Did you palpate that patient's muscle group? Did you use a monitor in the original video? You used neither of them. You used vision, as we typically do. Well, as this Text explains, vision is not a method to determine twitches. Palpation is, or a monitor. And I have tried this since reading that text, and it is extraordinary that you can palpate, put your hand on the muscle group that you're stimulating, then stimulate the patient's nerve, and you will be able to detect more subtlety in the twitches. You will be able to feel the fade where your eyes will not be able to see the fade. That is the biggest difference with palpation. This is another example. This is an EMG version of the same concept. Both of these patients have 4 visible twitches. The patient on the left, you see clearly that the EMG signal decreases upon each twitch. That is representative, as we know, of fade, which is a non-depolarizing neuromuscular blocker or phase 2 block with succinylcholine. This patient's muscle group twitched 4 times. Then look at the patient on the right. 4 twitches visibly from the patient and clearly no change in the EMG waveform. Each one of these were full depolarizations of the muscle group, and that patient actually has 4 twitches. This is an example of that same concept. This is a photograph of the TwitchView monitor that I took when I gave a cardiothoracic anesthesiology fellow a break. I went in and the patient had 1 twitch. The patient was undergoing an open thoracotomy. The monitor was on, and as I said, the patient was at 1 twitch. As the ASA states, that is less than 4 twitches and 40% train to 4 ratio. So that means that the patient should have received only Sugamidex for its reversal agent. And I left when the resident returned from their break. I reported off that the patient did have 1 twitch. They were beginning to close. So later in the day, I saw the patient rolling down the hallway with a face mask, oxygen from the operating room to the recovery room. The patient was seemingly doing well. They were oxygenating well on the monitor, on face mask. The patient was extubated, of course. And I looked at the chart to sign off on that chart. And instead of Sugamidex, the fellow had given neostigmine. Knowing that the ASA states that that should not have happened and that will not result in full recovery of the patient, I then connected the patient to the TwitchView monitor in the recovery room after neostigmine reversal. And this is the photograph of the TwitchView monitor of the extubated patient in the recovery room. They clearly have fade. They clearly have residual neuromuscular blockade. The EMG waveform, the 4 twitches clearly decrease on each twitch. So this is the perfect example of a patient extubated but still having residual paralysis. So I then gathered around our OR pharmacist and the head nurse of the recovery room and the patient's nurse and any other nurses who were available to listen. And I described that this is the clinical scenario that we can now eliminate with the use of monitors and Sugamidex. So I then injected 50 milligrams, 50 milligrams of Sugamidex into the patient. And I described the clinical scenario over the next 3 minutes. And then I took another photograph of the patient's monitor, and this patient was now reversed and at 96%. You see the EMG waveforms on the left are all equal now. This patient who had an open thoracotomy is now not paralyzed and is now in a much lower risk for having complications postoperatively, specifically pulmonary complications. Okay, so let's go over some quantitative monitoring methods. The gold standard that is that every other type of monitoring is measured to is called mechanomography. Unfortunately, mechanomography is big and bulky. You make it in a laboratory. It is not clinically available. But yet this is the gold standard. So all the other methods are measured to that to see how closely related to mechanomography they are. You may have seen some of these devices. Accelerometry is on the left. It uses similar technology as your cell phone to determine how fast you're going down the road when you're driving. It determines how quickly that thumb is moving each of the 4 times and see if there is deceleration. Then the one on the right is called kinemography. I've recently used this at the University of Wisconsin Medical Center in Madison. It is easy to use, and however, it is unreliable simply because if the hands are tucked or bumped in any way, the data then skews very erratically. The most closely related to mechanomography is electromyography. That is what Blink TwitchView monitor uses. During a voluntary contraction, the EMG action potentials are sent from the brain to the motor unit, ultimately leading to the contraction of the muscle fibers. EMG, therefore, allows us to measure the electrical response of the muscle or its action potential, and that is what is shown on the monitor. We'll go over the anatomy of the ulnar nerve and the adductor pollicis. We see the ulnar nerve innervating the pinky finger and ring finger, but then the ulnar nerve takes a sharp 90-degree right-hand turn and innervates the adductor pollicis. This is another view of it, the ulnar nerve in green going down the lateral side of the hand, and the median nerve innervating everything around the adductor pollicis, but the adductor pollicis in green is innervated again by the ulnar nerve. This is why it's very important to put the probe on the adductor pollicis and not on the adjacent muscles, because you will get inaccurate data if you're putting it on the wrong muscle group. This is from the TwitchView website. It really is like GPS for neuromuscular block. It tells you where you are, it tells you where you are trying to go, and it tells you when you get to your desired location. This is a very good representation off of their website as well. Number one, the patient has been induced. Propofol has been injected. The play button is started on the monitor. It goes through its optimization phase and shocks the patient and determines that the patient is 100% trend to 4 ratio or 100% recovery. Then you inject the medication at number one, and you see the patient falling down. Their neuromuscular function is falling down into the trend of 4 level, and then even sub trend of 4, which of course is post-tetanic count. Over the course of time, the patient recovers through spontaneous metabolism. Then number two, a maintenance dose of paralytic was injected. The patient decreases again into the post-tetanic count zone. Over time, metabolizes up into the trend of 4 level. Then the surgeon states that they're done. You determine that it's time for reversal. You inject the reversal at number 3, and then the patient increases their neuromuscular function to number 4, which is on the right, 90% trend to 4 ratio, which is the standard of care. This is a great representation of when I was going through my anesthesia program ages ago. Can you even imagine that if the patient had no twitches or one twitch, we were taught and told to wait? We simply had to wait. There was nothing to do. We either waited in the operating room, or we waited in the ICU, or we waited in the recovery room until the patient regained some muscle function, where then we could inject a maximum dose of neostigmine and see if the patient would then regain enough strength to where we felt like they would probably fly. That's the best that we could do. Now we can do so much better with the advent of Sugamidex and the quantitative neuromuscular monitor. We do not have to wait anymore. This is now the present. This is a chart which states that not only neostigmine is an option, but also Sugamidex. You see that Sugamidex has been put on the right-hand side along with neostigmine. Per the ASA guidelines in 2023, neostigmine has now been eliminated from shallow blockade, and is only to be administered when the patient is in minimal blockade, as I mentioned earlier, which on the left tells you that it's 4 twitches and between 40% train to 4 ratio and 90% train to 4 ratio. You can, per the ASA, consider neostigmine as a reasonable alternative to Sugammadex. Other than that range, it is Sugammadex all the way. You can administer however much this Sugammadex that the patient needs to recover to 90%. I will also highlight that at the end, at the very bottom of this chart in green, acceptable recovery is train to 4 ratio greater than 90%. Look to the right of that. If the patient metabolizes the drug to 90% on their own, how much reversal agent are you to administer to the patient? The answer is 0. The patient has metabolized themselves. It doesn't matter how much paralytic they had received in the case. You are not to administer reversal agents if the patient does not need to be reversed. You will only administer reversal agents if the patient needs reversing. So gone is the CYA dose or the cover the chart dose or do it for the lawyer dose of reversal. That is now no longer. This is a video of injecting Sugammadex while the patient is 26% train to 4 ratio. This is a video that lasts about 3 minutes, showing everyone how quickly the patient recovers with an injection of Sugammadex.
All right, we have a train to 4 ratio 26, 4 twitches. And then we're going to give some Sugammadex, 200 milligrams. Tell you when we get this.
This is the little one, yeah. Thank you so much.
All right, Sugammadex going in.
Okay. Thank you so much.
Squeeze the Sugammadex in. Yeah. Monitoring this every 10 seconds.
You have leftover wet and dry. I'll spill that so you can have some left to break and get to bed. Thank you. Fresh. They never get clean. Asking your little anesthesiologist.
761. We're getting there.
You don't have any specimens, do you, or that? No specimens. Okay. Thank you for it, little, thank you. Appreciate it. Prefer not to dumpster dive. I prefer not to ever dumpster dive. I can get it over here in the office, plans. There's that like little bridge that's gonna make it. No, ma'am. Thank you. Oh, thank you so much.
We're about at a minute and a half now. About 89. Okay.
Huh?
Okay, as we can see now, the patient is successfully reversed and ready for extubation. This TwitchView monitor pushes all of this data into the Epic chart. So it does all the charting for you, and the patient has now documented full recovery and the elimination of residual neuromuscular block. The TwitchView monitor allows us to be very precise. We can now deliver precision anesthesia. This is an example of me administering 3 20 milligram doses of Sugammadex. One 200 milligram vial was diluted into 10 cc's. 1 cc was given approximately every 10 minutes. I did this for many reasons. One, I wanted to see how far the patient would get after 20 milligrams. And then also I wanted to see how long the patient would continue to recover after one 20 milligram dose. And as you see, the patient will plateau. There is a point in which recovery ceases with a dose of sugammadex. That time was 10 minutes. The patient will continue to recover for 10 minutes until recovery stops. And if you're not 90%, an additional dose of sugammadex is needed. It doesn't matter if this is 20 milligrams, 100 milligrams, 200, 400, 1,000 milligrams. If the patient is not 90% and they need more, they simply need more. So, since we had seen so many interesting results using the TwitchView monitor, we applied for a research study, an IRB research study through the University of Mississippi Medical Center, where we wanted to titrate sugammadex to train-to-4 ratio. IRB approved our protocol, and I will describe some of these results now. This is our research team. Myself, Dr. Zach Khan, Dr. Austin Khan, and our OR pharmacist, Dr. Yasmin Eloa. The results of this titrating sugammadex study is the subject of a full presentation that really delves down into all of the data. Every p-value was less than 0.05. The smallest p-value was 0.000007. So we hit the center of the bullseye on this data. We did 105 patients with the titrated sugammadex protocol. And some of these results that I will discuss, 102 of the 105 patients required less than the FDA recommended dose. 2 of the 105 required actually the recommended dose, and 1 patient required more than the FDA recommended dose. Notably, 70 of the 105 required 100 milligrams or less. So about 70% of the patients required 100 milligrams or less. The average weight of our patients were 87 kilos. The average rocuronium dose that the patients had received by any and every anesthesia provider was a total of 69 milligrams. The average FDA recommended dose of sugammadex that the FDA would have recommended us to give these patients was 254 milligrams. The average sugammadex that was actually required to get our patients to 90% train-to-4 ratio, which is the standard of care, was actually only 92 milligrams. The range was 20 milligrams of sugammadex all the way to 260 milligrams of sugammadex. The patient to the right was my 8th patient, B8. This patient recovered to 98% train-to-4 ratio with 1 injection of 20 milligrams. In terms of milligrams that we administered or were recommended to administer to our 105 study patients, the FDA recommended we give 26,695 milligrams of sugammadex. The amount of sugammadex that we had to inject to our 105 patients was a total of 9,700 milligrams. In terms of vials, if you look at it that way, because we are popping tops regardless, based on the FDA recommended dosing, we would have opened 174 vials. We actually only had to open 107 vials. Adverse outcomes, there were no adverse outcomes reported by the study team or by the patients themselves. Each patient had my cell phone number and my email address. Break it down into savings for the facility. The titrated protocol for our 105 patients cost $7,700 or $73 per patient below the FDA recommended dose for those patients. Over the last 12 months, UMMC had administered Sugammadex to 8,805 patients with a total drug acquisition cost of $1.1 million. Using the titrated protocol, if each one of those 8,800 patients had received the protocol, they would have done two things. One, each patient would have met the ASA standard of care, 90% trinophore ratio, and cost $646,000 less than the FDA dosing recommendation. The best example of this information is my 13th patient, B13, was 184 kilograms, and at the time of reversal was a trinophore count of 1. This, of course, would have recommended 4 vials. So 184 kilos times 4 milligrams per kilo would have been 738 milligrams administered to the patient. And the patient actually recovered to 90% trinophore ratio after 100 milligrams, or 1/2 of 1 vial. There are more potential savings even possible. Fixed dosing. If 87% of our anesthesia providers are administering a fixed dose, why not give a 100 milligram fixed dose? We could break the 200 milligram vials into 2 100 milligram sticks. If you just feel like injecting the entire stick, which is not common practice with any other medication, namely phenylephrine, we titrate phenylephrine. We should also titrate reversal agents to 90%. If the patient is still not recovered after 100 milligrams, if they're still only sitting at 50% trinophore ratio, let's say, we'll simply give another stick. And then you're actually back to what you would have given anyway. Also, some facilities are purchasing 500 milligram vials and splitting them into syringes. The 500 milligram vial is also slightly cheaper than the 200, potentially providing 5 doses of 100 milligrams from each vial versus just 1 vial being utilized for each individual patient. Then also generic Sugammadex. Bridion is patent protected until June of 2026. We don't know if that is going to actually come to fruition, but generic Sugammadex is on the horizon at some point. For the people that just give 200, well, which guideline are you following? Are you following the FDA guideline or are you following the ASA guideline for the administration of Sugammadex? Because per FDA guidelines, 2, 4, or 16 milligrams per kilo would rarely, if ever, be 200 milligrams. Obviously, you would have to have a 100 milligram, a 100 kilo patient times 2 milligrams, or you would need a 50 kilo patient times 4 milligrams per kilo, both of which would be fairly rare. If you're following the ASA guideline, which is 90% trinophore ratio, of course, bringing patients to 90% would rarely, if ever, be 200 milligrams. So which guideline are you actually following? Because giving 200 milligrams either does one of two things. It underdoses your patient and you still extubate a paralyzed patient, which is the whole purpose of why we're here. Or you overdose the patient, giving more molecules than the patient actually needs, potentially increasing expense and also the risk of side effects. Sugammadex is not benign. Okay, so I broke down the cost associated. The average FDA recommended dose of our 105 patients was 254 milligrams at a cost of $228 per patient. The titrated cost analysis, 200 milligrams per 2 mil, was $114 per vial, which is 57 cents per milligram. But if you broke it into 2 100 milligram syringes, that would be $57 per stick. If you then went to the 500s, that cost of that vial was $210 or 42 cents per milligram. And if you broke that down into 5 100 milligram sticks, it would be $42 per dose. And 70% of patients would recover with that dose, potentially taking you from $228 per reversal to $42 per reversal. Okay, we'll go over some takeaways to finish up here. As everyone would agree, we should return every patient to their pre-paralytic state, how they were in the pre-op holding area, which is, of course, 100% recovered. That's how we would want to be when we recover from anesthesia. We can accomplish this by whatever means necessary. It doesn't matter what method. When you use a peripheral nerve stimulator with the proper technique, customized with baseline, patients who have 4 twitches, no fade, sustained tetany, breathing, a good tidal volume, head lift, and following commands can still be 50% paralyzed. The whichever means necessary includes spontaneous metabolism. They can metabolize the drugs on their own and they do not need reversal agents. Or if they're in minimal block, neostigmine and glycopyrrolate. If the neostigmine and glycopyrrolate is injected and they still fail, they're still below 90%, they should then get a dose of Sugamidex, like the example of the recovery room thoracotomy that I gave earlier. Or if the patient is deep enough for just Sugamidex only, that's all you have to do is inject Sugamidex until the patient is 90%. Another takeaway here, our eyes cannot detect the extent of neuromuscular paralysis in the same way that our eyes cannot detect the percent of oxygen bound to hemoglobin. So then what did we do? We invented the pulse oximeter that can see. Therefore, like the pulse ox, neuromuscular blockade can only be accurately measured by a monitor. 10 on the temple is not a technique, we simply made it up. One common question that I get frequently is, do I need a baseline with TwitchView? You don't. Not exactly. However, pre-paralytic startup at the beginning of the case, before the paralytic is injected, it allows the monitor to optimize the stimulation parameters for each individual patient, and you, the clinician, seeing the initial measurement allows you to confirm correct electrode placement and data capture. You see that the patient is 100%. Then you inject the paralytic and you see the patient go to 0. If the patient does not come back after succinylcholine, you know that the patient has pseudocholinesterase deficiency. If the patient does not come back, you see that they have very slow metabolism and will require Sugamidex. And with the baseline, with the TwitchView, it's the same technology, the same science, the same concept of peripheral nerve stimulation. So you should be getting baselines with the peripheral nerve stimulator for the exact same reason. Peripheral nerve stimulation intends to stimulate nerves. Peripheral muscle stimulation is not a technique. And we achieve peripheral muscle stimulation. That is what we are looking at when you overstimulate and put 10 on the temple. Quantitative neuromuscular monitoring changes the way we deliver anesthesia, gases, narcotics, paralytics, reversals, etc., which that change can be the most challenging for the most experienced providers, people who have been doing it for a long time the same way. We can accurately measure the depth of paralysis now, only now, for the first time, and it looks very different from what we've been doing our whole career. The patient's recovery from neuromuscular blockade looks very different than what we ever imagined it was, which is okay. Ultimately, the only thing that matters is that the patient recovers to 90%. Regardless of the method, the drug, the dose, it doesn't matter. We're here to take care of patients. We're here to recover patients back to their pre-paralytic state. The need for reversal agents, their appropriate dosages, and the patient's confirmed recovery can only be determined by the quantitative monitor. That's it. Our eyes cannot determine it. We cannot see the neuromuscular junction, just like our eyes cannot see oxygen nor hemoglobin. The standard of care, 90% train to full ratio, can actually be achieved in a much more efficient manner than is currently being practiced with broad, blind, round doses of reversal agents, specifically expensive Sugamidex. This is a great example. to finish with, this is a screenshot of a patient's chart, a 20-year veteran nurse anesthetist who had done 20,000 cases in their career, had the TwitchView monitor connected to the patient. This is just when we had rolled out TwitchView into our anesthesia department. This 20-year veteran knew what a recovered patient looked like, and despite the fact that the monitor was on the patient, reading 4 twitches and 37% recovery, the patient was extubated. The CRNA decided to extubate the patient, and they left the operating room headed to PACU. This is the problem. This is what we're fighting, and this is what we can now eliminate. We can eradicate residual neuromuscular blockade from anesthesia. If you send your patients, which currently you send 50% of your patients to PACU paralyzed, if you're not using a monitor and you're not confirming 90%, you are sending the patients to the recovery room or to the ICU in a much higher risk category for developing complications, for leaving the operating room slower, for leaving the recovery room slower, from not coughing and deep breathing, developing pneumonias, and in some cases, as you know, get re-intubated, require re-intubation for respiratory failure in the recovery room or the ICU due to residual neuromuscular blockade, and then the patient finally going over the cliff, wearing out, and needing to be re-intubated, all of which could have been eliminated, eradicated, and never even been an issue. So this is the problem. This is how TwitchView helps us eliminate residual neuromuscular blockade. And if you are using the monitors, congratulations. We are now in the new age of quantitative neuromuscular monitoring, and we are practicing to the standard of care, which is bringing every patient to 90% train to 4 ratio. I am more than happy to answer any questions that may come up. Thank you for your time.
All right, thank you, Blake, for that insightful presentation. If you haven't already, please take a moment to type your questions into the Q&A chat box, and we'll do our best to address as many as we can with the time we have left. To get us started, I will kick off with a question that came in earlier. So Blake, what advice would you give to increase acceptance and usage in departments that are just beginning to use the monitor?
Sure, that is a very good question. And as a resource, as a reference, I would go back to the 2023 ASA guidelines on neuromuscular blockade and recovery. They actually dedicate a significant portion of that document to support and how to implement the practice. There is going to be resistance from anesthesia providers. We've done the same thing for so long, and we believe that our patients have done well. Just like the anesthesia providers before 1987 who had never used a pulse oximeter were then introduced to the pulse oximeter and said, "We want you to use this." Those anesthesia providers felt like they did a wonderful job and that they knew when their patients were oxygenating properly. It's not their fault. They did not know that they could do better because there was no technology to show how off we were. Then the pulse oximeter came. It did not look normal. It did not look like what we thought the patient should be oxygenating, but it is true, and now we use it every single day. So similar challenges will be present in the department as you roll this technology out for the same exact reasons. But the ASA does provide a good rollout, including there needs to be a champion. There needs to be a champion in the department who knows the technology, who knows how to implement it, who knows how to troubleshoot, who knows how to use these drugs in the correct dosages to achieve 90%. And then just to simply and gently and thoughtfully, steadily over time, impress upon their colleagues to use the monitor. And it never fails. As soon as you use that monitor and as soon as you reverse a patient to 90% and you see it with your own eyes, you will believe it, you will do it forever, and now you will not ever want to paralyze a patient without the monitor again.
All right, another question that's come in. What are your 1 or 2 top troubleshooting techniques?
Sure. Um, Troubleshooting is a large part of it. When you see erratic data, you will need to troubleshoot that monitor. In my experience, and specifically, I'll go back to our research study of the titration of Sugamidex. 3 of the 125 patients that we began the protocol on, 3 of those could not get accurate data because of technological difficulties. 3 of 125. So it is very rare, but it does happen. Similarly, going back to the pulse ox, how many times do you use 10 pulse ox probes, 1 on each finger? Then number 11 on the forehead, number 12 on the ear, number 13 on the nose. Why would you put 13 SAT probes on the patient? It's because you don't believe that that is the correct SAT. You are troubleshooting. You are attempting to get a SAT that you are comfortable with. So similarly, if you're not getting accurate data or data that you trust with the TwitchView, you will troubleshoot. Now, some of the most common are a cable could be malfunctioning. That is fairly common, especially in the early versions. The TwitchView cable has now been upgraded several times, and so now cable malfunctions, which typically involve the patient's bed being pushed over the cable and breaking the cable. Those are almost eradicated now because of the larger and bulkier cables. The probe itself, just like a SAT probe, sometimes the SAT probes don't function properly. It is very rare. And now in my 6th year of using the TwitchView on virtually every case, I have seen 2 probes that were not giving good data that I put a new probe on and it actually worked. So hundreds and hundreds of patients, 2 probes were bad. 90% of them are user error in my estimation. I have taken several photographs of user error, putting the probe not on the ulnar nerve, but on the median nerve, putting the electrodes not on the adductor pollicis, but on the thumb or the knuckle. Even one photograph showed one of the probes being placed on top of the tegaderm, which was covering an IV. All of those scenarios result in erroneous data that is not able to be trusted. Inevitably, the user will say, this monitor isn't working correctly. Well, actually, if you had the probes in the correct place, you would get the accurate data. So that is really 90% of it is user technique. And I still mess up. Sometimes if the patient is positioned in a rare position and I'm facing the other direction, maybe I'll put it on the median nerve and then I don't see correct data. I look back at the probe and then notice that I have it on the median, not the ulnar. So it just takes practice, basically.
All right, next question. How would you describe the ease of use and learning curve for the monitor?
Learning curve is very quick. However, it is substantial because it is like going from never using a SAT probe to using the SAT probe. And just like I described, putting multiple SAT probes on patients to get good data. So the learning curve is certainly present, but the monitor, and I have now used several quantitative monitors. TwitchView is only one of them, but out of all of them, TwitchView is the most, in my opinion, most user-friendly, easiest learning curve, gives you the most data, the most accurate data because of its EMG technology. So that is actually, the learning curve is very, very easy, but it certainly is present. And I think that's why a champion needs to be there in the department.
All right, we have another question. Were there any issues with pharmacy having reservations about splitting the vials and storing pre-drawn up doses of Sugammadex? Our pharmacists have concerns of stability of it being pre-drawn up and stored out of the original container.
Sure. Each facility will have its own pharmacy guidelines. The credentialing of the facility will dictate which federal rules you go by for the drawing up and storage of medications. So you really have to go by your facility's guidelines and work with your pharmacy department at that facility to determine what methods, if any, are available for you to split vials. This would have to be a ground up, grassroots effort, really. It would have to consist with the leadership of the anesthesia department, the pharmacy. I would assume several meetings to describe what the rules are and how we would go about doing it, and if it's something that would be feasible. One of the reasons why I brought our OR pharmacist on our research team was so she could be directly involved and then come up with recommendations that she could then take to the pharmacy. She is the one who recommended us split vials. There are guidelines that you must follow as far as drawing it up under the hood. How long would it be able to be stored in the drawer at room temperature? How many could you store in the refrigerator? So on and so forth. But all of those um, issues that we would face, we felt like we could adequately navigate and save money.
All right, I think we have time for one last question. So the question is, we have used quantitative neuromuscular monitors to measure muscle relaxation during cardiovascular procedures, especially in patients undergoing coronary artery bypass surgery. How does the EMG behave in hypothermic patients? Is there anything in particular we should consider regarding EMG signal reliability, baseline, or recovery monitoring under these conditions?
Sure. I personally have not used it in hypothermic patients. However, I am unaware of any reservations in using that data. I don't believe that hypothermia would affect the patient. Dr. Andy Bowdle is a cardiothoracic anesthesiologist, and he has written multiple papers on the EMG technology and the quantitative neuromuscular monitor. I would reference his article published in June of 2023 in the Journal of Anesthesiology. Not only is his article the first titrated Sugammadex dosing article published, but also the editorial in that same issue of anesthesiology. The editorial points us to this technology and points to the future of our usage of it and how we should shift all of our efforts to using this technology. Dr. Bowdle's study was done on cardiothoracic patients that had been on bypass. So that's why I would refer to his article and that I am unaware of hypothermia.
All right. Well, thank you, Blake, and thanks to everyone who joined us today. We hope this session gave you valuable insights into how quantitative neuromuscular monitoring and the TwitchView Trainer 4 monitor can enhance anesthesia practice and patient safety. A recording of today's webinar will be shared with all registrants, and you can find additional resources at blinkdc.com. On behalf of the Blink Anesthesia team, thank you for attending, and we look forward to seeing you next time.
Thanks, everyone. Thank you, Katie.